Welcome back, everyone. Alex Chowdhury is my name. I'm the Director of Infectious Diseases at the Prince Charles Hospital. It's great to see all of you attending today. I have the privilege of chairing session 2, and to keep things exciting, there have been a few changes. 2 of our speakers are going to Zoom in, so you can imagine my trepidation trying to make this work. And Dr. Andrew Burke will go first instead of Dr. Bradley Gardner. Andrew is a dual ID respiratory physician and a most valued team member in our department. Andrew is essentially the mycobacterial guy for us. He's currently undertaking a PhD in the pharmacokinetics and drug dosing of antimycobacterial drugs for both in TB and NTM. He's also on the WHO TB advisory group and also chair of the Australian Tuberculosis Network. I could go on, and while it's a privilege for us to have him on the team, anytime we get a complex or even simple mycobacterial case, sometimes I think the rest of us at Charlie's are getting a bit lazy with mycobacteria because of his breadth of expertise and experience. Without further ado, Andrew, over to you, and hopefully the tech holds up.
Yeah, thanks. I'm sorry I can't be there. I've got COVID as of this morning. My wife just texted a photo 2 seconds ago of our son's positive test, so I'm sorry I can't be there for a great session, and I love the first session as well. So I'm going to talk about NTM infections and transplantation. Sorry, I can't get rid of the top slide, which you can probably see, but this is just to orientate you to the issue for some of you who may not be that familiar with non-tuberculous mycobacteria. So this is a 31-year-old with Mycobacterium abscessus. He's got renal sarcoid. He's been immunosuppressed. He's also got type 1 diabetes, which is a risk factor. And you can see here we have this cavity. See if I can just get my pointer going. He's had this cavity, he had Mycobacterium avium complex in Townsville last year, and then over 3 months it's rapidly progressed. And he's only a young man, obviously, and he has Mycobacterium abscessus, which is a rapid growing mycobacteria. So I'll go through what these mean in a moment. And I'm not sure if Timothy Wells is still there. Tim gave that great talk on cloaking antibodies, but I'd emailed Tim. So if Tim, if you're still there, I'm going to be emailing you about some of these patients. So if you look about mycobacterial lung infections, so we're most familiar with tuberculosis. Your TB is the #1 killer again, now that COVID's sort of gone down, fortunately, in mortality at least. So TB is the #1 pathogen killing people globally. And then you've got Mycobacterium leprae or leprosy. And then in high-income countries like Australia, non-tuberculous mycobacteria accounts for most of our clinical cases. And so we divide these up into slow growers and rapid growers. And Mycobacterium avium intracellulare is the most common slow grower, and Mycobacterium abscessus is the most common rapid grower. And the taxonomy for these NTM can be quite confusing. But suffice to say that Massiliense here tends to be more macrolide susceptible and therefore carries a better prognosis. So this is a slide, I suppose, which could be applied generically to lots of transplant infectious diseases. And with NTM, we're seeing more of it. You know, when I was a registrar at Princess Alexandra and Royal Brisbane 16, 17 years ago, I don't think I looked after one NTM case, but now they are occurring with more frequency. And there are a number of different factors which will interplay on prognosis and perhaps treatment, whether it's the type of transplantation, whether it's pulmonary or extrapulmonary or both, the susceptibility profile, particularly macrolide resistance, and the drug interactions and drug dosing can be complex. And some of our patients are on dialysis, as are a couple of cases I'll share soon. So if we look at the risk factors for NTM, this is a meta-analysis that was performed, looked at about 85 confirmed cases. And these aren't super common compared to, say, fungi or CMV. So this was 85 cases over 10 countries and I think 20 transplant centers. So they had to cast a wide net to get these 85 cases. The risk factors they found were older age at transplantation, hospital admission within 90 days, antifungal use, and lymphocyte-specific antibody therapy. And a lot of these patients do have concomitant fungal disease or other pathogens such as Pseudomonas, and so there's an overlap and perhaps a diagnostic delay or dilemma in trying to attribute some of the symptoms and signs to the non-tuberculous mycobacteria. And there's quite a wide range of prevalence documented around the world, and we'll go into that soon. So probably numerically most are and renal transplant, just because it's the most common solid organ transplant, but lung transplant has the highest risk. And again, not to dwell on the taxonomy too much, but if we look at what are the most common two pathogens we worry about are Mycobacterium abscessus complex and Mycobacterium avium complex. And in lung transplant, we tend to see a bit more Mycobacterium abscessus. In renal transplant, we might see more slow-growing Mycobacteria. So if you look at the lung transplant risk factors now, so the previous meta-analysis I showed you was all solid organ transplant. Perhaps not surprisingly, cystic fibrosis is a risk factor for NTM, as is pre-transplant infection. And this is an issue I'll touch upon at the end of the talk. So probably in that previous meta-analysis, 25% of people who had post-transplant NTM had pre-transplant NTM. So it was sort of there and had been treated but not cleared, and then had relapsed. Or we thought we'd cured it, but we hadn't. And certainly NTM does, in the lung transplant population, does increase mortality and the risk of chronic lung allograft dysfunction. If we look at hematology stem cell patients, again, this is maybe not a prevalence of about 1.2%. But I was in Taiwan a few weeks ago for a mycobacterial meeting, and Taiwan has a huge amount of NTM, including abscessus, and they have a prevalence of 5%. So to put Taiwan's situation in context, at Prince Charles, we might treat 4 to 6 patients per year. They would have about 30 per year at each of their main hospitals. So East Asia, Taiwan, Japan, South Korea, the world leaders in research in this field, mainly because they have so much of it. And certainly in the hematology patients, stem cell patients, there's a high mortality of about 33%. And the pathogens that we see, in this case, are mostly MAC, and abscesses were less common. And although we traditionally associate mycobacteria with pulmonary infection or a pulmonary source, we are seeing an increasing number of bloodstream infections and extrapulmonary disease. And we certainly had one of our hematology patients at the Royals had, I think it was Mycobacterium chelonae bloodstream infection, probably from an infected permacath site. So this is the first patient I'll go through, and this is a renal transplant patient who's been managed in Lismore, and Sarah Coghill, who's a hardworking ID physician down there, has spoken to me about this patient in the last couple of weeks. So this is a 49-year-old woman who's had a renal transplant back in 2000. Her transplant is failing at the end of last year, and she's planned for a living donor transplant sometime this year. And she's been back on dialysis since November of last year. And she has had some waning immunosuppression, but she's still passing quite a large amount of urine. She had fevers and dialysis noted in November of last year, but was otherwise stable and systemically otherwise quite well. And she had a right lower lobe lesion noticed on chest X-ray and confirmed on CT scan. And you can see it here. It's fairly well circumscribed. And one of the differentials for this was obviously malignancy, including post-transplant lymphoproliferative disease. She had a PET scan which showed significant avidity, both in the right lower lobe mass you can see, but also around some mediastinal nodes, and also below the diaphragm, extensive FDG avidity in the mesenteric and retroperitoneal nodes. And as I said, at this stage, malignancy was considered the most likely, including PTLD. She had a CT-guided biopsy, and it showed granulomatous change. It was culture negative for mycobacteria, but they did a PCR, and it came back as PCR positive. This is December of last year. And then, I guess in view of that, they went on to do urine cultures, specifically trying to culture mycobacteria. And this cultured Mycobacterium avium, which then allowed susceptibility testing. This lady was on dialysis, and so she was put on renally adjusted dosing for ethambutol, which was given post-dialysis, and rifabutin and azithromycin. So the rifabutin has less interactions with tacrolimus and so on. And she did have an attempt to wean immunosuppression. A few months ago, however, she had increasing right lower lobe consolidation and increasing splenomegaly and intra-abdominal lymphadenopathy. Again, she remained relatively well, but ongoing fevers. And the PET scan showed progression of her disease. And again, the concern was that maybe the diagnosis was incorrect and that NTM wasn't the main driver for this. So she had I should go back, sorry. You might notice she had a supraclavicular node, which is present. So I'm just going to get my pointer up if I can. This was not present before. And so she's had a ultrasound guided biopsy of this, and it's culture positive for MAC. And likewise, she had she had a lap chole because of concerns of cholecystitis, and she had mesenteric lymph nodes biopsied, and again, they're still culture positive despite several months of NTM treatment. Initially, the thought was maybe this is like an iris picture as well, like she's had a weaning immunosuppression, and maybe this has got worse. So the thought was, well, maybe this is an immune reconstitution process, but the positive cultures are against that. We're lucky that our pathology Queensland, we have assays for all of these drugs now, and TDM was performed, and one of the thoughts was that maybe she's subtherapeutic, but these are all in the ballpark. And we've changed the rifabutin to clofazimine, and we've added in ceftriaxone based on one study which suggested activity against MAC, and given the risk of amikacin in this patient, and whether coincidentally or not, the fevers are settling over the last couple of weeks. This is a bilateral lung transplant patient who's had rheumatoid arthritis and had a transplant in 2020 for ILD. And he had this progressive change in the left lower lobe. He also had Pseudomonas here, but persistently smear positive for Mycobacterium abscessus. And he had a difficult time post-transplant. He was on ECMO for quite a few weeks and was dialysis dependent after that. And he's had a complex of regimen, which I'll go through in a moment: tigecycline, cafoxidine, IV amikacin, drugs we probably wouldn't usually use outside of NTM infection in this country, and clofazimine and azithromycin. Initially, we had quite a good response. My phone, sorry. This is the treatment paradigm that we tend to use for Mycobacterium abscessus. And if you look up, if you have a patient with this is what you tend to look up. And it's divided up into like an initiation phase and a continuation phase. And so this fellow had tigecycline and amikacin, and we used cafoxidine because of the ease with dialysis of dosing it post-dialysis. And he actually did reasonably well. He had about 4 to 5 weeks of this regimen, seemed to be responding clinically, and was put on an oral therapy, and he's remained on that since then. One of the problems with Mycobacterium abscessus treatment is that there's a high degree of heterogeneity in the way people treat it. And this is just to show you 26 different patients from Europe. There's an NTM network there, and all of these patients have had liposomal amikacin. And this is to show you, this is the duration in weeks, and the red here is intravenous therapy, and the bluey grey is oral therapy, plus or minus inhaled antibiotics, amikacin. You see this person here has had 75 weeks of intravenous therapy with amikacin, imipenem, meropenem, tigecycline. This person's had only like a few weeks of IV amikacin, and you see there's a complete sort of mishmash, and this is from people who know what they're doing. And so this is one of the problems with abscesses, is that we have these guidelines, but the evidence base is quite limited. And what we really have is that, unlike Mycobacterium avium complex, we have a reasonable degree of concordance with how we treat. We have this petting zoo of antibiotic options, and the poor old ID physician has to sort of try and decide which of these he or she is going to choose. And there's to date very little clinical trials or no clinical trials that will help decide that. So this patient I just discussed was randomized into the format study, which is the first attempted randomized controlled trial for Mycobacterium abscessus. It's been run largely out of Brisbane. Professor Claire Wainwright, who's pediatric CF physician at the Kids Hospital, she's a chief investigator, and we're grateful for all the support. And we're quite about 20 sites in Australia now recruiting, and a number of international sites coming online this year. And it's an adaptive study, and I'll show you the different treatment arms in a moment, but our patient was randomized to one of 3 treatment arms. And then basically patients have cultures or BAL done at 4 weeks. And depending on whether they're still culture positive or negative, they get randomized into other, it's quite a complex study. And I won't sort of go into it in too much detail. Suffice to say that we're lucky we have this randomized controlled trial that can help sort of gather data on this for our patients. So he was randomized intensive RMA, which meant that we had to give IV amikacin instead of inhaled amikacin, and he had oral clofazimine. Everyone gets tigecycline. We get a choice of imipenem or cafoxidine, and everybody gets azithromycin. And he was still, unfortunately, culture positive at 6 weeks, despite feeling well. So this is now another randomization point. He could have been randomized to another 6 weeks of IV, so 12 weeks in total. But he was randomized to consolidation arm, so an early switch to oral therapy. And he was also received inhaled amikacin based on the randomization process. And there's also a degree of quite a bit degree of clinician latitude as to what we choose there for the oral backbone therapy. So he's gone through this and he's actually doing reasonably well. He's culture converted after about 6 weeks of therapy. He had Mycobacterium abscessus maculaense, which is macrolide susceptible, which carries a more favorable prognosis. This was a 53-year-old man with had a heart transplant in 2022 for dilated cardiomyopathy. Again, he had a difficult post-transplant period and was on dialysis, unfortunately, after his transplant. A prolonged ICU stay at Prince Charles. Last year, he was on his dialysis at the Royal Brisbane Hospital, and he had fevers and delirium, and the dialysis nurses took blood cultures, which were culture positive for Mycobacterium abscessus. And again, he had similar. He couldn't be on the format study because it was considered an extrapulmonary infection at this time, but he had similar sort of antibiotics to what we've discussed already. This pleural effusion was tapped, and at that stage was culture negative. Unfortunately, despite initially doing reasonably well, he had a relapse, and this was then recultured, actually progressed since that earlier CT, and this time was culture positive for Mycobacterium abscessus. So he's got an NTM empyema, a bloodstream infection, and so because he'd failed on treatment, we gave him some ceftazidime avibactam, which is not in the guidelines, but avibactam is a novel non-beta-lactam beta-lactamase. It's a bit confusing, but it overcomes the beta-lactamase that Mycobacterium abscessus produces. And so we tend to pair it with imipenem and other beta-lactams. Unfortunately, despite that, he had refractory infection and died after 6 months of therapy. He had a PET scan, and this is not the bladder, it's actually a retroperitoneal mass. He had a perforated sigmoid colon, and this collection was present, and it was too high risk, unfortunately, for it to biopsy. But the concern was that maybe he had a Mycobacterium abscessus collection, which was the source of his ongoing infection. So this is my final couple of slides. One of the problems we have is, can we transplant people with Mycobacterium abscessus in terms of lung transplant? And unfortunately, often, because of concerns about this progressing on immunosuppression, unfortunately, this is often quite a strong relative contraindication to transplantation for our lung patients. So this is a 45-year-old woman who's got primary ciliary dyskinesia, and she's had treatment for abscessus multiple times over several years. She was a late diagnosis of this, what we call a ciliopathy. So the cilia in your airways aren't working. She had infertility, which in retrospect was which would have been due to this. And she had to go through IVF. The cilia and the fallopian tubes are absent as well, and so it does predispose to infertility. And she was diagnosed at about 40 years of age, though, with bronchiectasis due to this. She's had multiple courses of antibiotics, probably 3 to 6 months in total of IV therapy over several years, and remains culture positive. And she's really quite cachectic and quite unwell. And unfortunately, she really needs a lung transplant. Unfortunately, because she's still culture positive and smear positive, our lung transplant team have felt she's too high risk, and that's been discussed with colleagues in Sydney as well for a second opinion. And so when we look at this, because this is a major issue, is NTM post-transplant. And this is looking at not just pulmonary transplantation or lung transplantation. Sorry, this is all just lung transplantation. And we looked at people who had NTM-PD or pulmonary disease pre-transplant. About half of them end up with it post-transplant. And of those, about 12% died of it, or a death attributable to NTM. And so you think about when we have a lung transplant, you keep your trachea and you keep your left and right main bronchus. So you do have that large airways are intact. And if they're still colonized with abscessus, then you don't have effective source control. There's been some variation in the literature about survival with abscessus post-transplant. This was sort of a favorable study in 2019 out of California, where they looked at 7 patients who were transplanted with abscessus. All survived, but they were all what we call smear negative at the time of transplant. So they had polyporsal bacillary infection, and they all had fairly aggressive treatment pre and post. Against that is a CF study where 7 children with macrolide resistant abscessus, and this lady does have macrolide resistance, they all died post-transplant, so a high mortality in that cohort. And perhaps this cohort may be more reflective of her other patient, acknowledging she doesn't have CF, but she does have smear-positive abscessus and hasn't really responded well to treatment, unfortunately. So just in summary, I mean, NTM, it's relatively uncommon maybe compared to other infections, but it's still very serious. And unlike, say, fungal disease and CMV, where we have some good randomized controlled trials, unfortunately, that's really lacking at the moment in NTM. We do have increasing awareness of it, and there's a lot more discussions about it. And so the pharmaceutical industry are becoming more interested in this infection because of the length of time that you have to treat people for, so 12 months. So there's obviously a commercial incentive as well to be able to find new therapies for these patients. And I think just for those of you, who may not be respiratory or lung transplant physicians, in lung transplant, they all get cultured for mycobacteria every time they have a bronchoscopy. And that's how we picked up that TB case that was discussed in the first session. It wasn't expected to be TB, but just a screening bronchoscopy found TB, the donor-derived TB. But for those of you who may be, say, renal transplant physicians, you've got, widespread lymphadenopathy, you might be thinking about lymphoma, you should consider non-tuberculous mycobacteria. And as our case in Lismore showed, doing blood cultures for mycobacteria, maybe considering urine, obviously sputum, BAL, and biopsies, but you specifically have to think about NTM and ask for those investigations specifically. So I'll just stop there, Alex, and happy to answer any questions.
Thank you, Andrew. I don't know if anyone else was twitching at the thought of 70 weeks of amikacin, but some of these cases certainly demonstrate the determination and resilience of the IRD physician. Not to mention from a patient's perspective, their renal and hepatic fortitude.